Anatomical changes. The enlarged uterus pushes the diaphragm upwards, which displaces the heart upwards and to the left. The heart rotates slightly to the left, shifting the apex beat to the fourth intercostal space, 2.5 centimeters outside the midclavicular line. Abnormal clinical findings. Palpitations due to heart displacement. Pulse rate increases slightly, sometimes with extrasystoles, extra heartbeats. Systolic murmur may be heard due to decreased blood viscosity and great vessel torsion. Mammary murmur, continuous hissing murmur, may be heard over the tricuspid area due to increased blood flow through internal mammary vessels. Doppler echocardiography shows an increase in left ventricular and atrial diameters. Third heart sound S3 is common, sometimes fourth heart sound S4. ECG shows normal pattern except for left axis deviation. These are normal physiological changes, but caution is needed to differentiate from heart disease. Cardiac output starts increasing from the 5th week and peaks at 30-34 weeks, 40-50% increase. Highest in lateral and knee chest positions and lowest in sitting or supine positions. Increases by 50% during labor and 70% immediately after delivery due to autotransfusion, blood squeezed out from the uterus. Returns to normal within 1 hour post-delivery and to pre-pregnancy level in 4 weeks. Causes of increased CO. 1. Increased blood volume. 2. Higher oxygen demand due to fetal and maternal metabolic needs. 3. Increase in stroke volume and heart rate by 15 beats per minute. A normal heart can handle the increased load, but a damaged heart struggles. Blood pressure. Systemic vascular resistance (SVR) decreases due to progesterone, nitric oxide (NO), prostaglandins, and ANP. Despite increased Colorado, blood pressure decreases due to reduced SVR. Diastolic BP and mean arterial pressure (MAP) drop by 5 to 10 mmHg. Venous pressure. Antecubital venous pressure remains unchanged. Femoral venous pressure increases due to uterus pressing on iliac veins, especially on the right side. Non-pregnant state. 8 to 10 cm HO. Pregnancy lying down 25 cm HO. Pregnancy standing 80 to 100 cm HO. Leads to physiological edema, varicose veins, hemorrhoids, piles, and deep vein thrombosis (DVT). Central hemodynamics. No significant changes in central venous pressure (CVP) MAP and pulmonary capillary wedge pressure (PCWP) despite increased blood volume, cardiac output, and heart rate. This is because of 1. Decreased systemic vascular resistance (SVR). 2. Reduced pulmonary vascular resistance (PVR). 3. Lower colloidal osmotic pressure. Supine hypotension syndrome, postural hypotension. During late pregnancy, the gravid uterus compresses the inferior vena cava when lying supine, reducing venous return to the heart. Most cases compensate via collateral circulation, paravertebral and azygous veins. In 10% of cases, venous return is severely reduced, causing hypotension, low BP, tachycardia, high HR, syncope, fainting. Turning the patient to the lateral position quickly restores BP. During labor, uterine contractions increase venous return, preventing hypotension. Regional distribution of blood flow. Uterine blood flow increases from 50 ml per minute non-pregnant to 750 ml per minute near term. Breast blood flow increases from 1% to 50% of CO. Pulmonary blood flow increases by 2,500 ml per minute. Renal blood flow increases by 400 ml per minute from 16th week onwards. Skin and mucosal blood flow peaks at 500 ml per minute by 36th week, causing heat sensation, sweating, and nasal congestion. Metabolic changes. General metabolic changes. Total metabolism increases due to fetal growth. Basal metabolic rate (BMR) rises by 30%. Protein metabolism. Positive nitrogen balance is maintained. Fetal and placental protein content equals 500 grams. Maternal protein gain equals 500 grams stored in uterus, breasts, and blood. Blood urea decreases, but uric acid and creatinine remain unchanged or slightly lower. Amino acids actively transported to the fetus. Carbohydrate metabolism. Increased glucose transfer to the fetus. Insulin secretion rises due to hyperplasia of pancreatic beta cells. Insulin resistance increases 44% due to hormonal changes HPL, cortisol, progesterone, estrogen, TNF-alpha, etc. Pregnant women experience fasting hypoglycemia and postprandial hyperglycemia, hyperinsulinemia. Glycosuria is common 50% of pregnant women due to increased GFR exceeding tubular absorption threshold. Fat metabolism. 3 to 4 kg of fat is stored, mainly in the abdomen, breasts, hips, and thighs. Plasma lipids and lipoproteins increase due to estrogen, progesterone, HPL, and leptin. HDL increases by 15%, LDL is used for placental steroid synthesis. Iron metabolism. Total iron requirement equals 1000 mg, mainly in the second half of pregnancy. Fetus and placenta equals 300 mg. Expanded red cell mass equals 400 mg. Normal losses equals 200 mg. Iron absorption increases, but still insufficient without supplementation. Pregnancy is a state of inevitable iron deficiency, but fetal iron levels remain adequate. Systemic changes. Respiratory system. Diaphragm elevates by 4 cm, reducing total lung capacity by 5%. Subcostal angle widens, chest expands. Hyperventilation occurs, increasing tidal volume and respiratory minute volume by 40%. PACO decreases 32-38 mm of mercury. POW increases 95-105 mm of mercury. Right pointing arrow facilitates oxygen transfer to fetus. Respiratory alkalosis with partial renal compensation. Urinary system. Kidney size increases by 1 cm. Renal plasma flow and GFR increase by 50%. Ureters dilate and become atonic, leading to urinary stasis, higher risk of infections. Alimentary system. Gums become swollen and bleed easily. Slowed gastric motility. Right pointing arrow. Heartburn, constipation. Gallbladder atony increases risk of gallstones. Nervous system. Mood changes, sleep disturbances common. Postpartum blues or depression may occur. Carpal tunnel syndrome and thigh numbness due to nerve compression. Skeletal system. Increased pelvic joint mobility causes backache and waddling gait.